My name is Tanoh and I'm a paramedic.
My name is Julia and I am a senior sister in the emergency department.
So speaking of the emergency department, from the perspective of a paramedic, have you ever noticed that when we come in with our patients, we will tell you one story and a patient would then tell you a completely different story or add to the story in a way that was meant to be important for us to tell you, but then we haven't been given the opportunity to tell you because they thought, well, I'm just going to tell the nurse instead. I'm not going to tell the ambulance crew.
Yeah, but I think there's probably a couple of reasons for that. I think depending on the nature of why they've called you, if they are really stressed and upset, it might just be that actually that hasn't crossed their mind, depending on the important bit of information that they've missed out.
Yeah.
And I think that's probably why we do our own triage process, because that journey to the hospital, probably calming down, maybe you've given some pain relief, they've settled a little bit, and then they're like, oh, actually, yeah, probably should mention this. But yeah, I think that does happen quite a lot, and that's why we do our own triage as well. So you guys probably think, oh, well, why are they asking the same questions that we ask? And the same things happens as when we're doing a triage with the ambulance, and we triage them to a certain area of the department, maybe it's a less acute area, and then the doctor will then do their own assessment, and then the information can change as well, because maybe it's the questions we ask, I don't know, but yeah, so stories can change along the way, but it does happen, you're right.
I think part of it may potentially be a little bit from a respect of the role perspective. I'm not saying that the public disrespect what we do as paramedics as such. I think it's potentially a slight misunderstanding of what our purpose is. So most people are going to know that, well, we're there, or most people are going to assume that we're there to take them to hospital, where they know that in hospital, that is where I need to tell them absolutely everything that they need to know. So I think there may be a bit of an assumption on the patient part, maybe, that they think, well, I don't feel like I need to tell them that bit as such, which that will probably change in time when our role gets more established to the public and they do realize actually we are quite skilled in what we do and what we know and all that kind of stuff. But it's a good one for anyone on the come up in our role as well, because I remember when I was a student, when I was emergency medical technician, and handing over to nurses, and the patient will add on that extra bit of information. Yeah, I've got nine coronary stents. Why didn't you tell me that? And I used to feel almost a little bit embarrassed when I'm handing over, because I'm like, oh, I did ask, but they didn't tell me.
The kind of how people view your role, I think we have very much the same thing, and it can be whether people are from a different country where people's roles are different. I remember we had a lot of Spanish nurses before Brexit, and I remember some patients saying, oh, nurse, can you get me a cup of tea? And they're like, what? We don't, in Spain, we don't make cups of tea. We're really valued for our medical knowledge. So, things change across the country, and also decades. I think that, my mum said to me that when she was younger, nurses basically did bedpans and got cups of teas and sandwiches and stuff like that, and did the washes. Whereas now, obviously, our role has grown so much that we have healthcare assistants that do that. And now we've even got trainee nursing associates that are going in between the healthcare assistant role and the nurse role. And nurses work so autonomously, and they do lots of advanced roles, and paramedics, advanced paramedics that intubate patients. So I think that the public don't actually realise how much our roles have progressed, and how skilled we are, and how educated we are, and how we're constantly updating our skills. You guys bring in cardiac arrest. And actually that brings me on to a question I've got to ask you. Is that all right?
Yeah, of course.
So I think that, obviously I know what you guys did. I've worked in A&E for a long time, I've worked as a nurse for a while. I think the first time that I really, really had appreciation for paramedics it was a night shift, and it was way before COVID. It was when we actually had a bit of a lull in the department. It wasn't too busy. I was in recess. And then there were some patients that self-presented at the ambulance doors. And they were major trauma patients, I'm not going to say any more. And obviously we had to bring them straight into resus. And it was the first time that I realised that actually, so normally, obviously, you know, and just for you guys, when a patient's coming in and they're being blue lighted, they're a priority call, they're a major trauma, a stroke call, anything like that, we get a pre-alert from the ambulance service, it's the call centre, isn't it, control centre, and they tell us, they're like, this is what's coming in, this is how long it's going to be. And straight away, without even realising it, your mind is preparing for what could potentially come in. So it's like you're setting up for a trauma, you're setting up whether it's a really unwell asthmatic, cardiac arrest, anything like that, you're setting up. And even though you're going to autopilot and you're getting all the equipment ready, your brain is also getting ready for what you're going to see. But suddenly these patients turn up extremely sick. And I remember thinking, oh my God, because there was no time to prepare. And I remember thinking, this is what paramedics have, because, you know, 9 times out of 10, you will attend a call and actually, you know, even what you're saying about the patients not telling you everything, you know, when they see you as a paramedic, that's probably the same to the 999 call handler. So what you're thinking that you're going to might actually be completely different. And suddenly you've just got to be able to get into action like that. And that was like a real respect that I had for you guys, because you have to think quicker than we do. I just wonder how you deal with that.
In that case, in those cases, we definitely do. I think for a lot of people, it's just having that understanding that this is just what the nature of the job is. Like we come into work or I would come into work and think, what is going to happen today? What are we gonna attend to today? Is it going to be just a day of sort of medical emergencies? Is it going to be medical mixing with a little bit of trauma? Is it going to be the medical emergency or the medical scenario that's caused a trauma? Like you just never know. And you know what? I don't even know how we get used to it. But for me personally, you just kind of do. But I think that adds to the enjoyment of why I love doing that role. So I think for me, that definitely helps. Like enjoying the fact that, well, you're just not going to know until you actually get there, and then you actually have to deal with it. And then there is that bit that you say about the having to deal with it pretty much within seconds, depending on what it is when you have actually arrived on scene. You know, sometimes you might be right on top of a scene and you are there within like 1 or 2 minutes, so you don't really have that much time to think. Sometimes it might end up being quite a bit of a long run because, you know, the area that you're working is so busy that you're having to travel quite a few miles to get there. So to be fair, we do sometimes have that opportunity to think things through as one is driving and the other one's in the passenger seat. We're like, okay, right, if it's this, do you mind doing this part whilst I do this part? So for example, as you say, like a cardiac arrest, if you know that you're definitely going to be the first one on scene, you can be like, okay, do you mind getting on the chest to do chest compressions whilst I get the pads on? Or if we know that potentially somebody else is going to be there doing chest compressions, because dispatch, if they can, will like instruct somebody to do chest compressions if they can. So we might go, okay, cool. If there's a bystander doing chest compressions, do you mind getting the pads on whilst I get some equipment ready to manage the airway and that kind of stuff? So if you do have the time to do it, then we definitely do it. Looking at what you guys do, like managing, let's look at the majors department, for example, or minors or furthers, like so many different hospitals call it so many different things. To be able to have that level of bandwidth to know what patients you have in what bays, because you could be looking after 3, 4, 5 patients at a time sometimes?
Well, it depends really what level of nursing you're at. But yeah, generally, sometimes 5, or sometimes we put a nurse that will be looking after the patients on the chairs in majors. They can have like 20 patients on the chairs.
Which to me, that to me is wild, because it's like, that's, yes, as much as in certain areas they might not be as unwell as others within the department, but that's still like 20 human beings, like to have to manage to look after. That's 20 people who could potentially have a question for you. That's 20 people who might have already been seen by a doctor who then needs sort of medications given. And of course, you're working in a team as such, but there's still always more of them most of the time than there is of you.
Absolutely, yeah.
And trying to weigh that up and watching you guys weigh that up, I'm just like, how on earth do you guys do this, like sort of 3 times in a week or 4 times in a week, or however many shifts you might have in a week? And going back to you saying that you're a senior nurse, so I take it sometimes you're in charge.
Yeah, so if you're in charge of the department, you allocate your staff in the morning. So you have a nurse that will be in charge of each area. So the nurse in charge of resus, a triager for ambulances, nurse in charge of majors, etc., etc. So you allocate where you feel that you're making your department safe. Obviously, there are staffing issues, as you know. But yeah, so I think if I'm in charge, I end up doing about 1 million steps because we have such a massive department. And obviously you're monitoring things on the computer, so looking at patients and their presentations, but you're constantly walking around, checking everything's all right, checking the timing. If there's a really long wait for a doctor, it's like, right, we need to pull a doctor from another area because these patients need seeing. And what you're saying about patients that are on the chairs, if there's a really long wait for a doctor, which can happen overnight, just for sheer volume of patients coming in, you need to be aware that actually, although those patients, when they came in, they were okay, people can deteriorate.
Yeah.
So it's really kind of having your mind, like, these patients need their like observations, so like blood pressure, pulse, all that kind of stuff, doing really regularly, so you can identify those patients that might be becoming sicker, because not all patients will tell you, actually. You know, some people are like, oh, I didn't want to bother you. And those are generally the ones that you've really got to be very careful about, because they can just go. So you're always aware that you're never comfortable and relaxing, because anything, as you know, at any time can just go. When we had COVID, the threshold of what was brought into hospital changed, didn't it? We've kind of gone back to where we were in terms of the early warning score, you know, which is basically, for people that don't know, it's how we score patients based on their observations. And it gives us an indication of how sick they might be. So if they were septic, we'll be looking at blood pressure, pulse, temperature, all that kind of thing. So depending on that score would be whether the paramedics would decide that they needed to come in as a priority call, or if they could just be conveyed, you know, not on a blue light, and obviously we assess them when they come in. But sometimes we'd answer the phone and be like, why are they bringing this patient? Like, these look fine. Why are they bringing this?
That is a classic.
And we'll be like, we'll eyeball it at the door and we'll see. Because, you know, generally, and it's really hard, because actually sometimes people will present to us and their numbers on paper are absolutely fine. But you look at that patient and you're like, no, you are not well. Like, you just know, don't you? Develop an instinct. But I think that you guys sometimes really feel like you have to justify why you've brought a patient in. Do you ever feel like that?
Yeah, and like, I think with ambulance staff and A&E staff, we do have this sort of mutual understanding kind of thing. And I get it. Like, I suppose at the end of the day, we're all just human beings. And, you know, when we talk about it amongst ourselves, like, oh, you know, I brought in, or I tried to pre-alert this presentation to hospital. So, you know, as you said, calling ahead to let them know that we're coming in with a certain presentation that we think is quite bad. And then they'll say, yeah, but the nurse said they'll eyeball it at the door. They said, you know, and I think sometimes some of our crews can feel some kind of way about it, which I get it. But again, I suppose with experience, you then understand why that nurse has done it. Like, it's not personal. I think sometimes it can be easy to feel like, it can be easy to take certain things like that personally, when it really isn't. Like, we need to pay more attention to things like, or have a bit more of an understanding of, well, how busy is the resuscitation department, where the sickest patients are going to be. We don't know that. Like, we're lucky that we don't really have to think about that information. We don't know who's in the majors department. We don't know what staffing levels are like. We don't know any of these things, but we do know that this patient is sick and we want to bring them in. But I think, we need to, at times, just have that pause for thought when we think, oh, like, why has that nurse said, like, go to the front door? Why has that nurse said, like, they're gonna eyeball it. Man, I know this person is sick. Like, ultimately, we've done what we think is right, and it will all work itself. It will work itself out in the end, like, you know.
And obviously, if they are sick and we eyeball them, like, you know, like, yeah, bring them in, we'd have to. And like, it's a constant juggling act in A&E. It's like, so if I'm in charge of resus, I feel like it's like playing a game of pool. You've always got to be one shot ahead.
Yeah.
So I'm thinking, okay, we've got a 10-bedded resus. So I've already thinking, if that phone goes off, and that phone can go off 3 times in 10 minutes, because different crews can all attend a really sick patient and they all need to bring them in. So I need to know constantly what patients I've got, how sick they are, who's ready to be stepped down. I can step them down to a less acute area.
Yeah.
So it's always, you know, and I've had it where a patient's had to go to a CT scan and then a new patient's come in, I've offloaded them into that bay and I'm like, okay, I'll figure out where that one's gonna come when they come back. But we never turn away a sick patient if they're really sick. But sometimes they could be like, actually, you know what, we'll get the consultant to see them in a less acute area straight away and we'll start medication, we'll start them and then if we need to come in, we'll get them in.
Just going back to how you said you do like 1,000,000 steps. Yeah, my A&E placement was like 6 or 7 years ago and I still remember like the amount of steps that I had to do on those couple of days. I was thinking, I don't want to go back, man. I don't want to go back. Like this
it's like you've run a marathon when you get home.
This is wild. Like who needs leg day? Who needs calf day when you're doing that many steps in an A&E department? It is wild. Like
you need comfortable shoes. That's what you need.
Yes, you do. It's mad. Absolutely mad.
I come home sometimes and like my feet are swollen, I'm aching all over, and I'm like, oh my God, I feel like I've literally just been to the gym for 10 hours. That's probably because I'm getting old as well. But yeah, it's like, and you can see why people burn out in the emergency department, because it's fast paced and it's constantly, and it's like since COVID, it's so busy. I mean, you know yourself, like there's certain targets when ambulances come to the hospital that we need to offload them, as in we need to take that patient and let the crew go.
So we can go back out into the community.
Yeah, exactly. And then, I mean, originally it was like 15 minutes, wasn't it? Or 10, I can't remember what it was originally. It seems so long ago. But we have what's called a black breach, and that's if the crew are there for longer than 60 minutes, and then the hospital gets quite a big fine. But then, like, sometimes, I remember, like, years ago, if there was a 30-minute delay to handing over, everybody was like, the performance were like, you know, what's going on? We need to offload this patient. But now, I mean, especially this winter just gone, there'd be like shift reports that I'd seen, there'd be like 15 ambulance crews that we've been there longer than an hour. There was a time that we actually had an agreement with a London ambulance service that they would cohort patients because we couldn't take them. So the paramedics were staying there overnight looking after the patients in an area of the department. It's just so busy. Is it frustrating for you guys when you go into hospital, it's the end of your shift, I'm thinking, you know, it's an hour till you clock off, you got to take this patient to hospital and you know that you're not getting out of there.
Yeah.
There's nowhere for that patient to go.
Yeah, and you know how it is in that classic thing of never make plans like after work. Because like you just know, and even if it's not because you have to go to like convey a patient to hospital and that hospital is busy and you know you end up running over your shift and all that kind of stuff. Just in general, you just know something is gonna happen. Don't know what it is, but something's gonna happen and them plans are out of the window.
Yeah.
But in terms of that side of things, yeah, it can be frustrating. For me personally, it's not anymore because again, looking at the bigger picture, as bad as it is for us that we have to wait here, it must mean that it is 10, 20 times worse in the hospital. So what is there really to, like from a personal perspective, what is there really to complain about? And it's more so what can we do for that particular patient? And you know how it is where a lot of us crews are going out to more of the elderly population. That's the ones that kind of worry me or make me a bit sad / frustrated because it's like, okay, cool, we're going to be outside in the ambulance. It's the patient who's going to be on our bed, which over time gets really uncomfortable.
They're hard beds, aren't they?
What about when they need to go to the toilet, or what about if they're wearing sort of a pad which might help with incontinence and they need to be changed? How are we going to be able to facilitate that? just making sure they stay hydrated, all those little things which in hospital can be done like 10 times easier, then become a lot more difficult because they're now like confined to the back of our ambulance. I mean, from a nursing perspective on that side of things, like the sort of non-clinical, non-academic side of it, I've learned a lot, like in terms of being able to like change patients and all of that kind of stuff through these delays, which is good. But yeah, it can be frustrating. And I think we've had quite, in my experience, some of my colleagues who are a bit newer, so have joined when it has been like so busy. Like imagine, I suppose, joining at a time where you might go to a patient, that patient you've assessed, you know, you've done a really good job in doing all the skills that you've just learned, and think, oh, yeah, I think we need to take you to hospital. You then get to hospital and then you're there for hours. That then means that you're not really spending much time going back out to the community to then go and
learning,
assess, and care for as many people as you can. So, you know, I've had it with colleagues that they get really like sort of frustrated or a bit down about that kind of thing, and to then end up finishing late on top of that doesn't really help. But for me, it's not really that. It's not really that frustrating anymore. It's just where we are now with things, and we just gotta hope it gets better.
OSANII TV, it is a wrap.